All right, so everybody should see my screen, correct? If I can get a thumbs up. Awesome, sounds good. And actually, let me play from current slide. All right, I hope nobody joins us because can't see them. All right. There we go, perfect. All right, so tonight we are covering spine, brain, and nervous system injuries. So with this topic, with this chapter, we are talking about, like I said, what happens with the brain, what happens with the spine, and look at the nervous system. The objectives we're going to go over tonight, so we're going to identify and define the two major anatomic components of the central nervous system. We're going to define traumatic brain injury, describe traumatic injuries involving the spine, describe the signs and symptoms of spinal injuries, describe how to properly assess a patient with a suspected brain and spinal cord injury. We're going to list the signs of traumatic brain injury. We're going to demonstrate how to properly care for a patient with a brain or spinal cord injury. We're going to demonstrate how to maintain proper spinal alignment while placing somebody onto a long backboard, whether they're seated or supine. What does supine mean?
Laying down, face
laying
up.
Down.
On your back.
How are they laying down?
On their back?
On their back, absolutely. I always remembered supine by thinking like it looks kind of like spine. All right, and then we're going to explain and demonstrate how to perform neutral head alignment and how to demonstrate how to apply a C-collar. We're also going to demonstrate how to perform an axial drag, demonstrate how to secure a patient on backboard, how to use a full body mattress, how to remove a helmet, and we're going to talk about this principle called jams and pretzels. All right, our key terms tonight, we're going to talk about all these. We're going to make sure we go over them as well. So getting into the overview of the chapter. So working outdoors in a ski environment, or not so much a ski environment, but in an outdoor sporting environment, head, neck, and spinal injuries exist. And these can be from something super minor to something totally life-threatening. So when we talk about minor, we're talking about like a minor concussion. Life-threatening, we're talking about cervical fracture to C3, 4, or 1, 2, or 3, right? Those are going to be our cervical fractures are going to be like the most life-threatening we can think of, all right? And also too, talking about head injuries and brain bleeds, those can also be very deadly. So we want to make sure that we do a proper assessment to identify any kind of issues that may be present. This last bullet point, CNS trauma is associated with high mortality and morbidity rates. So that means that there's high death and injury rates that occur. Significant economic consequences. So when we talk about somebody who suffers a spinal injury, right, and they become paralyzed, that individual is now no longer able to contribute to society, and that can have some severe economic factors. And then lastly, it can have a severe impact on patients' quality of life. If we look at probably a most recent example that we're probably all aware of, we look at that police officer that was shot in June recently during the riots, right? He now is living on a ventilator the rest of his life. So he definitely has had some serious quality of life impairment due to that incident. So one of the most severe forms of CNS trauma is traumatic brain injury. And this is a leading cause of death of individuals under the age of 45. All right, so it's important for us to understand the mechanisms responsible for traumatic CNS injuries and be able to quickly recognize the signs and symptoms of specific CNS injuries. So when we talk about the CNS, we're talking about the central nervous system. So as OEC technicians, we have to be able to safely manage patients with traumatic head and spine injuries and minimize additional injury, which can help reduce the morbidity and mortality associated with the devastating form of trauma. So we're going to start off by doing some anatomy and physiology. So this is something I would make sure that you commit to memory, 7, 12, 5, 5, 4. I have memorized those numbers, 7, 12, 5, 5, 4. If you remember that sequence of numbers, then that is how you remember the areas of the spinal column or the spinal vertebrae. So we have 7 cervical spinal vertebrae. We have 12 thoracic, 5 lumbar, 5 sacrum, and 4 coccyx. Now, the reason why I would commit this to memory is because every test I have ever taken asks about 712, 554 in some shape or form. I can't guarantee it's going to be on the OEC exam, but I can pretty much promise you, you will see 712, 554 in some way, shape, or form. So the axial skeleton consists of those bones and the cranium or the skull. So the central nervous system has 2 major components. The brain is basically the central computer, and then the spinal cord is a pathway from the brain to the rest of the body. And then we have the peripheral nervous system, and these are the nerves that connect the rest of the body to the spinal cord. So we have peripheral nerves. Let's see if I can grab a pointer. Let's see here. There we go. All right, so you guys should see my pointer. So we've got the brain, right? That's like our central computer. And then running down the spinal column is a spinal cord. And then with each, between each vertebrae is a nerve that exits, that comes into the vertebrae or exits the vertebrae. And this is what provides the feeling throughout the body. All right, so some common injuries. So when we talk about CNS injuries, they can either be closed or open. So when we talk about closed injury, this means that the integrity of the skull or spinal column is not compromised. So like we see over here in D, like how we have an opening of the brain, or correction, opening of the skull, brain starts to stick out, that would be an open injury. We see here with C as well, where we have a skull fracture there. That would be a type of open head or a open injury. Closed injuries are ones where we don't have that opening. The problem with open injuries is that blood and CSF can leak out. Also, too, it can cause exposure to the environment, which can cause infection. So skull fractures oftentimes can be felt or can be present with a soft spot or depression overlying the fracture with the contusion and tenderness of the scalp. This is pretty crazy to feel. So when we're doing our head exam, we're going to start with the top of the head. We're going to work our way down, right? But as we feel, right? If you feel, everybody take your hands, feel your head right now. I want everybody to feel your head, right? All right. So as long as your head is in, not compromised, right? You should feel how hard that is, right? Can you imagine feeling like a pillow? Like imagine like a pillow, like where your head is supposed to be, right? That would be an example of a skull fracture. So the problem is that CSF leaks out of the cranial vault and into the ear canals, nasal passages, or mouth. We may have ecchymosis or bruising that develops below the eyes. We call that raccoon eyes. So this individual has what we call raccoon eyes. Or we may have it behind the ears, and we call that battle signs. So that would indicate that we have some kind of skull fracture with CSF and blood leaking out. So this is a very important concept to keep in mind. A lot of recent studies into coup contra coup injuries. So when we talk about coup contra coup injuries, these are injuries that happen on the opposite side of the brain. So for example, what we see here is in this individual that got hit, that struck his windshield, we have the primary injury on the front of the brain. So remember, when the brain itself, or when the body is moving, right, all the contents are in motion. And then when the body itself stops, right, or the skin and bone stop, the organs still continue to move. So in this case, we see this individual is moving until he came to a sudden stop with the windshield, cracked the windshield. We have the primary damage of the brain where the injury is occurring. But what happens is the brain moves forward and then ends up bouncing backwards. And now we have a brain injury on the opposite side of where the injury took place. So we call that coup contra coup. The big issue with these types of injuries are swelling and bleeding, which can increase intracranial pressure within the skull. Remember, the brain itself, or the skull, cannot expand, right? So if we bleed into the stomach, you know, although that is a problem, right, it can be quickly fixed, right? And we can allow that expansion of blood in the stomach, right, or in the abdominal cavity. However, if we have that same amount of bleeding in the brain, that patient is going to die because of the amount of pressure that's going to happen inside the brain. So that's the issue with these types of injuries, is that they're very susceptible to swelling and bleeding, and can lead to brainstem herniation. So talking about traumatic brain injuries, so a traumatic brain injury is a mechanical injury to the brain that results in short-term and or long-term neurological deficit. There's different types of traumatic brain injuries. We have concussions, cerebral contusions, cerebral hematomas, including epidural, subdural, intracranial hematomas, and diffuse axonal injury. So some of the long-term deficits of traumatic brain injury include memory loss, reduced problem-solving capacity, stress and anger management issues, emotional upset, including depression, job skill impairment, chronic seizure disorders, functional changes in thought, speech, learning, emotions, behavior, and sensation, increased risk of Alzheimer's, Parkinson's, and other brain disorders that become more prevalent with age. So a concussion is a type of a TBI, which is caused by a temporary disruption of coordinated brain function caused by trauma. And we break concussions into mild, moderate, and severe. So when we talk about a mild concussion, that's no loss of consciousness, but the individual may appear confused, dizzy, may have nausea, vomiting, headache, and visual and auditory disturbances after a traumatic injury. So if you think about that snowboarder or skier that comes off a jump, lands wrong, and hits their head, and they're not wearing a helmet, although they may not go unresponsive or lose responsiveness, they may still be dazed and confused shortly after the incident itself, which would lead us to suspect a mild concussion. Moderate concussions are those that last less than 5 minutes and have a more pronounced disruption of the brain function. I like to equate these individuals to restarting the computer, right? So if somebody has a concussion, a lot of times they're trying to get their bearings from underneath them, right? They're trying to, reset the computer within their brain. And then severe concussions last about, longer than 5 minutes and have that significant disruption of brain function. Many patients who suffer a concussion exhibit some measurable memory loss known as amnesia, and the severity depends on the extent of the concussion. Now, I don't think it's in here, but if we're trying to gauge the level of concussion, what are 4 questions that we can ask a patient to gauge whether or not we suspect a concussion or not?
Time, place, name.
Person, place, time, event.
Person,
There we
place,
go.
time, and event. Absolutely. You may hear people come up with other questions like, is Mickey Mouse a cat or a dog? How many quarters in a dollar? Those are great questions to ask to assess brain function. However, we use the ANO times 4 status, where we want to know person, place, time, and event. And especially with concussions, by asking person, place, time, and event, we're able to see how serious that concussion is simply based on those 4 questions, because those questions are assessing different parts of the brain. So for example, if we ask somebody their name, we're assessing long-term memory type question versus a day question or a time reference or an event question, which may be looking at short-term references. So when we talk about amnesia, this amnesia is broken up into 2 different categories. We have retrograde amnesia and antegrade amnesia. Anytime we talk about something retrograde, we're talking about going back. So retrograde amnesia is no recollection of events prior to the injury itself. So that would be like you go up on scene and you assess that snowboarder who came off a jump, and you're like, hey, what's your name? They know their name, and you're like, tell me what happened. And they're like, I don't know. Can't tell you what happened. Right? That would be an example of retrograde amnesia. Now, antegrade amnesia is no recollection of events occurring after the injury. So this would be an example of you come up on that snowboarder, you're like, hi, my name is Sam, I'm a ski patroller, I want to help you, what's going on? He's like, I don't know what happened. And you're like, all right, I want you to remember the color blue. And now we get down to ski patrol and you're like, hey, what color did I tell you to remember? He's like, you told me a color? that would be an example of antegrade amnesia.
So Sam.
Yeah.
So the repetitive questioning, does that fall into one of these groups saying, hey, what's going on? And 5 minutes later, hey, what happened? Would that be qualified into antegrade amnesia?
Absolutely. And retrograde amnesia, because they have no recollection of the events, right? And they have the antegrade amnesia because they don't remember anything that you told them afterwards.
Copy that.
So we have this topic of perseveration, where patients with amnesia often have a distinctive speech pattern. And that's what Martha was talking about, asking about what happened, where am I, and basically what'll happen is they'll ask this question over and over again. So you'll have this patient that, you'll say, hi, my name is Sam, I'm ski patroller, what happened? Like, I don't know. You tell them, like, hey, I think you were involved in a traumatic incident. They're like, what happened? Where am I? What's going on? And they keep repetitive questioning. And so we refer to that as, like I said, repetitive questioning, where they ask the same question over and over and over and over again. Sometimes these patients can be very funny to work with. They come up with some very crazy things that they say. But at the end of the day, they definitely need to go down to the ER and get evaluated. Now, this is a very important concept that I want to make sure we hit. If antegrade amnesia lasts longer than retrograde amnesia, prognosis is worse. So, in other words, it's fine that they don't really remember the event right before, but we want them to remember things immediately after. And if that timeline is longer after the event where they're not remembering, they're going to have a worse prognosis, which means recovery can take months or even years. So moving into what we call a cerebral contusion. Whenever we use the term contusion, what are we referencing? What does the term contusion mean?
A bruise?
A bruise, absolutely. So putting that together, a cerebral contusion would be a bruise of the brain. And what happens here is that we rupture some small superficial blood vessels, and this is usually a localized area of the brain. And oftentimes patients present with identical signs and symptoms to a concussion, but it's more serious. So if the signs and symptoms are very similar to a concussion, how can you tell the difference between a concussion and a cerebral contusion?
Asking those questions, person, place, time, event.
But patients may present identical to that of a concussion. So how would you determine? So simply asking those questions is not going to be able to distinguish whether
How about
or not
feeling the head, feeling the injury site?
Okay. So let's say they have a closed head injury, right? We don't see any bruising, right? Because that bruising could be on the brain itself. So what happens if we don't see any bruising or we don't feel any soft spots? How can you tell the difference between a cerebral contusion and a concussion?
Check the pupils.
No, pupils. I mean, they're still going to be very important to check, but and then they may be sluggish in both cases.
You gonna get any fluid out of the ears, or?
Okay, that would lead us to suspect a skull fracture.
What about an MRI?
So I'll give you the answer. It's a trick question. You can't.
Yeah.
Okay, it's a trick question. As a ski patroller, you cannot tell the difference between a concussion and a cerebral contusion. Okay, so we cannot tell the difference between a brain bleed or a concussion. The only way that we're going to be able to tell the difference is to send them to an emergency room and get a head CT and have a CT of their head to assess for any kind of bleeding. And if there's no bleeding on the head CT, then it's assumed they have a concussion. So that's going to be the difference between our cerebral contusion and concussion, is with a contusion, we have some bleeding happening on the brain, and we need that individual to get a head CT. So as patrollers, if we come up on that individual that has the signs of a concussion, right? They're asking those questions. They don't seem to know what's going on. They can't answer our ANO questions. They're repetitive questioning. this might be an individual that, we may want to send down to the hospital by ambulance, or at least recommend that they get a head CT to ensure that they're not bleeding on the brain. All right, so now we have different types of hematomas. So when we talk about bleeding on the brain, it starts with a cerebral contusion. That's like probably the most minor form of bleeding. But then, we get into these different types of hematomas. So we have epidural hematomas, we have subdural hematomas, we have intercerebral hematomas. We're going to talk about all of them. All right, so an epidural hematoma is a traumatic brain injury that results in arterial bleeding between the skull and the dura mater. So if we look over here, we have the dura mater, and then we have the skull, and there's a bleeding happening between the two. And we see in this example how the blood pocket is putting pressure on the brain, and it's shifting the brain over. Typically, and the reason why they point out this middle meningeal artery is that's oftentimes the weak point that ends up rupturing, which causes that bleeding to occur. Generally, this is a result of blunt force trauma that causes a skull fracture. So in other words, we have that snowboarder that comes off a jump not wearing a helmet, lands really hard on our hard pack powder, and now they have that soft spot, and we would suspect a epidural hematoma. Or if we have somebody, let's say, that bangs their head slip and fall, can lead to this, especially in the elderly. Specifically with the elderly, the concern is that as you get older, the brain starts to shrink. And then what ends up happening is that the brain moves around a lot more inside the cranial vault. And then what can happen is that the vessels don't expand. So older individuals typically see these much more often than younger individuals because of the shrinkage of the brain. The onset of symptoms is very rapid. So what will end up happening is these patients follow this pattern, right? So we come up on scene, or bystanders report this unresponsiveness, and then they have this lucid interval. And this lucid interval is this period where they think they're fine. And then all of a sudden, later on, either minutes to days to hours later, they become increasingly less responsive until they are unresponsive. And it doesn't take a whole lot of energy to make these individuals have a epidural hematoma. I'll give you an example. The actress, I believe Natasha Richardson was her name. She fell in Canada. And she was on the bunny slope, was watching her kids, had one of those really stupid wipeouts, right? Like standing there, fell over. We've all been there, right? If anybody's been skiing or snowboarding, any length of time, right? When like you're standing in line, you lose your balance and you fall over, right? Super embarrassing. She had a very similar incident on the bunny slope, was watching her kids, lost her balance, fell over, wasn't wearing a helmet. She was initially unresponsive. Ski patrol checked her out. She was very embarrassed. She woke, she had this lucid interval while she was fine. She then retired to her condo that night, and throughout the night became increasingly unresponsive until she ended up dying from her brain herniating. So, this period of unresponsiveness followed by his lucid interval is very important, and we want to make sure we're monitoring these individuals to make sure they're not getting any less unresponsive. Without surgical intervention, it is very deadly. So a different type of hematoma that we have is what we refer to as a subdural hematoma. And this is a collection of blood between the dura mater and the brain. So we see here that the blood is below the dura mater itself, whereas in the epidural hematoma, it was above the dura mater. This is often caused by rapid deceleration injuries, and that goes back to what I was talking about as well with those older individuals with the shrinkage of the brain. We all see a lot of subdural hematomas. Similar symptoms to an epidural hematoma, but progresses much more slowly. Oftentimes, it's like I said, a much more slower bleed, but still deadly nonetheless. And what's interesting is that these individuals oftentimes have symptoms weeks after an insult. So in other words, you can have a patient that seems fine, you send on their way, and weeks later they start to develop headaches, they start to develop changes in mental status, changes in behavior, and they get a head CT weeks or months later, and now they have this subdural hematoma. And then we have an intracerebral hematoma, and this is basically bleeding within the brain itself. So in the other two examples with our epidural and subdural hematoma, the bleeding is above the brain. However, with an intracerebral hematoma, the bleeding is inside the brain. This can occur spontaneously or can occur from trauma and can be life-threatening because of the rapid rise of intracranial pressure. And usually prognosis is very poor for these individuals' anticoagulants. So a question that you might want to assess for somebody who's of older age is, what medications are they on? And if they don't tell you anything, specifically ask, are you on any anticoagulants? All right, and then we move into what we refer to as a diffuse axonal injury. So when we talk about an axon, this is a long, slender projection of a neuron that sends electrical signals away. A diffuse axonal injury is a devastating traumatic brain injury resulting in widespread brain injury. And so when the axons are damaged, that means that the brain is not able to function, the nervous system is not able to function. These are caused by high velocity rotational deceleration mechanisms, and these patients may be unresponsive at time of injury or become unresponsive. The thing about a diffuse axonal injury is oftentimes because it's happening at the cellular level or at the neuron level, it's very hard to see it on CT. In fact, many times you'll have a patient that looks fine, right? Like if you're assessing them, they look physically fine, but they are unresponsive, meaning you really can't see any trauma on their body, but they are physically unresponsive, and head CT is showing, very little. That would be somebody who has a diffuse axonal injury. And prognosis from a diffuse axonal injury is very poor. Many times, these are individuals that we refer to as being brain dead and start to be evaluated for tissue or organ donation. So these are going to be your candidates for organ donation. All right, and then we're going to move into spinal fractures. So fractures can happen of the spinal column. And these can happen from blunt, penetrating, compression, twisting, or distraction forces. They can also occur from hyperflexion, hyperextension, and rotational injuries, specifically to the cervical and lumbar regions. Blunt and compression trauma. When we talk about compression trauma, we have our vertebrae, we have that disc between our vertebrae, and the spinal column compresses on itself. So fractures of the cervical spinal column or cervical spine causing damage to the spinal cord can result in paralysis of the arms, legs, and loss of sensation below the injury. And specifically, we're worried about fractures to C3, 4, and 5. There's the old saying, C3, C4, and C5 keep the diaphragm alive. So basically, if we have a fracture that ends up affecting the spinal cord itself, that can cause the patient to not breathe. Meaning, if the patient has a fracture and is not breathing, what do we need to do for them?
Breathe for
Bag
them.
valve,
Yeah,
bag valve mask.
we're going to breathe for them. We're going to call for trauma pack. We're going to call for oxygen. And we need to initiate ventilations on these individuals very quickly. So we see here that we have an example of a fracture within the spinal column itself. Just because the spinal vertebrae is fractured doesn't necessarily mean that it is impeding the spinal column or the spinal cord. A lot of times what happens is spinal fractures is these processes, this is called spinal process, this protrusion. This spinal process ends up getting fractured. Technically that is a spinal fracture, and those typically heal on their own with very little intervention. What we're worried about is if the column itself becomes fractured, in which the spinal cord rests, and that's where we talk about the issues of paralysis. So vertebrae of the thoracic spine are protected from rotational injuries by the rib cage. Compression of the thoracic vertebrae can occur from a fall or axial landing. So that's where we're talking about the spinal column that's compressing on itself. And then upper thoracic spine fractures are less common than other vertebrae. Other spinal fractures, so most fractures of the spine occur in the lower thoracic and lumbar areas or at the junction of the two. Men experience fractures 4 times more often than do women. I don't know why, but that's very interesting to me. Injuries involving the lumbar vertebrae are due to twisting forces and sudden axial loading, which can violently compress the vertebrae. And this can also result from deceleration forces, as when deceleration flexes the lumbar spine in an individual restrained by a seatbelt. So seatbelts can lead to further injuries, right? If somebody's seatbelted in and their back is continuing to move forward, you can have an injury from that. Injury to the sacral vertebrae is rare. And does anybody know why the injury to the sacral vertebrae is rare?
Is it because it's mostly fused?
It's fused, absolutely. Yep. So because of that fusion that occurs in the sacral vertebrae, there's no movement, right? If there's no movement, there's less things that can break. However, when we talk about the sacral vertebrae, the coccyx is the part of the vertebrae, and this usually occurs when it falls on the buttocks. This is what we refer to as breaking a tailbone. So neurologic injuries of the spinal cord can result from direct or indirect injuries to the spinal cord itself. So a direct or primary injury can be caused by a broken or displaced vertebrae putting pressure on the cord, or a laceration of cord nerve fibers by sharp bone ends. Indirect injury can occur from pressure from a hematoma inside the bony spinal cavity or a canal, which puts pressure on the spinal cord, or traumatic swelling of the spinal cord resulting in blood loss, supply to the cord called neural ischemia. So when we talked about neurogenic shock, we talked about that earlier in the class. We talked about our different forms of shock. This is a form of shock that's caused by disruption of the autonomic nervous system. So what happens is the peripheral blood vessels below the injury dilate, which cause trapping in the capillary beds, which causes a precipitous drop in blood pressure, and usually occurs from a spinal cord injury. When we talk about hallmarks, we usually see that these individuals have bradycardia or a slow heart rate, and often a normal respiratory rate. And then we also consider, or sometimes we may see that redness below the spinal injury itself. Excuse me. And these can be potentially life-threatening. So we want to make sure that we treat them appropriately, treat for shock, put them on oxygen, get them down the mountain as quickly as we can. And we want to consider other causes of shock, especially hypovolemia, before thinking if it's neurogenic in nature. All right, so moving on to patient assessments. So if we have somebody who is, that we suspect is having a traumatic brain injury, we want to assess for a lot of different things. So we want to assess what's initial period of unresponsiveness. And that can be done simply by asking the patient, hey, do you remember everything? Did you black out? And asking bystanders, hey, did anybody see this individual black out? We can look for altered mental status. What 4 questions are going to lead us to suspect altered mental status?
Person, place, time, event.
Person, place, time, and event. We can also assess for a headache. What might a headache tell us?
Pressure.
What was that?
Pressure in their brain.
Hematoma.
Absolutely. We may see this nausea, vomiting from the increase in pressure. We may have slurred speech, similar to that of a stroke. We may have pupillary dilation or unresponsiveness. If we see that a pupil is dilated or unresponsive, does anybody know what that tells us?
Brain stem?
No, not brainstem. Can be though, but not the exact answer I'm looking for. So if we have a blown pupil, so if you look at one pupil and it's normal and the other one is blown or dilated, usually that means that there's pressure on cranial nerve 3. So when we look at the cranial nerves, there's pressure on that nerve that's causing the pupil to dilate. All right. We also can have this rise in systolic blood pressure and widened pulse pressure. So this is going to be a hallmark, this rise in systolic blood pressure. And also, too, this slow pulse. So this bradycardia. And there's a triad that we can reference. Let me grab, draw. There we go. I want to draw. All right. So we have a triad, right, or a triangle that we usually see with patients who have head injuries. And usually what we see in head injured patients with a cerebral bleed or with a brain bleed is we have an increase in blood pressure. We have a decrease in heart rate. And then we have irregular, I'll read as IRR, irregular respirations. And does anybody know what these three things combined equal?
Is it Cushing's?
Cushing's triad.
Cushing's triad, absolutely. Here, we'll write this on the screen. Cushing's triad. All right. So if you're assessing a patient and you see these three things happening, right, this is what we refer to as Cushing's triad. So increased blood pressure, decreased heart rate, and irregular respiratory rate. And what is Cushing's triad telling us? What's the importance of that? All right, so we talk about Cushing's triad. The importance of Cushing's triad is that we have some kind of, that we have possible brainstem herniation going on. So remember, the brain can only be held, there's only so much room that the brain can swell inside the cranial vault. So this is the cranium, right, or the skull. This is my brain, right? And my brain can only swell and receive only so much blood before it starts herniating and coming out the base of the skull. Does anybody know what the name of that hole is at the base of the skull that the brain can come out of?
Is it the
Foramen.
Foramen magnum, right? Foramen magnum. So the brain can be pushed out through that hole, and that's what we refer to as brainstem herniation. But typically, before people herniate their brainstem, right, we see this Cushing's triad. So this is a super deadly thing that if we see, we need to be acting very quickly. So we have that rise in systolic blood pressure and a widened pulse pressure. What do we mean by a widened pulse pressure? I know we talked about it once before. Does anybody remember what a pulse pressure means?
Difference between systolic and diastolic?
Absolutely, the difference between our systolic and diastolic. Good answer. All right, so moving into, we talked about slow pulse. We may have this lucid period after a period of unresponsiveness. What do we mean by this lucid period? What did that mean?
A period of clarity.
Consciousness for a little while.
Yeah, absolutely. So they're conscious, they're alert, and then they go into unresponsiveness again. We may have leakage of cerebral spinal fluid from the ears, nose, and open wounds. We may have slow or irregular respirations. Once again, Cushing's triad. Here, I'll grab my pen. Like if there's three of these that I want you guys to remember, it is Cushing's triad, right? So we want, that draw. I want to draw. I don't want text. There we go. That rise in systolic blood pressure, that slower irregular respirations, and that slow pulse, right? All those are going to lead to Cushing's triad, right? That's all bad stuff. We may have amnesia, dizziness, seizures, incontinence, numbness, tingling, or paralysis in extremities, posturing. What do we mean by posturing? Can somebody on camera demonstrate posturing for me?
That's the one your hands.
Yeah, I see Kelly's posturing. Yep, exactly, just like that, right? So we're gonna posture. Now we have two kinds of posturing. So what happens is in posturing, there's two kinds. We have what we call decorticate posturing and decerebrate posturing. So with decorticate posturing, what can happen is, and the way I remember decorticate versus decerebrate is with decorticate, their hands kind of come up to the core, right? Or if you think about it, the way I remember it is it kind of creates like a circle right here. If you see that circle that's been created on my body, right? What it does, here, actually, let me switch over to the camera. I'll demonstrate this a little bit easier so you guys can see me kind of on a bigger screen. Stop share. All right, there we go. All right, better for everybody. So the way I remember the different types of posturing, like I said, we got decorticate and decerebrate. So with decorticate, what ends up happening is that the hands kind of come into the core like so. But what it does is it creates, kind of hard to see it with my dark jacket on, but it creates almost like a circle. And what comes in a circle? A quarter. So I remember decorticate because I think a quarter and that circle that's created by the arms. Whereas decerebrate, they're posturing outwards like so. So we have decorticate posturing and decerebrate posturing. And that's going to be very important later on to be able to distinguish those differences in posturing, because later on we're going to talk about the Glasgow-Coma scale, where we're going to have to be able to distinguish whether or not they are having decorticate posturing or whether or not they're having decerebrate posturing. All right, so going back to screen share. Desktop one, dun, dun, dun. All right. So we are back. Ah, crap, I started from the beginning. That was dumb. All right, so skipping through, we went through this. Talked about amnesia. All right, so we're talking about patient assessment, and we were on posturing. All right, so posturing, what kind of posturing do we have? We have two kinds.
Corticate and I forget the name.
Decerebrate. Yep.
Decerebrate.
Remember, decorticate, we're making that quarter. All right. And then we can have paralysis. We can have raccoon eyes. What was raccoon eyes?
Two black eyes.
Two black eyes. Absolutely. And how about battle sign? What was battle sign?
It's like-
Bruising behind the ears.
Bruising behind the ears. Absolutely. All right. So moving on, talking about evaluating for traumatic brain injury. So the thing about traumatic brain injury is that we have to be able to rule out and think about other causes of that individual not acting appropriately, right? So that may include stroke. However, stroke can be very similar to a skull fracture, right? Or a brain bleed. That's what I'm trying to say. Stroke, basically is a brain bleed, right? The strokes tend to occur because of medical issues, whereas we're talking about traumatic brain injuries in this case. Low blood sugar. This most definitely can make you think that the individual has a traumatic brain injury. So can low blood pressure and drug or alcohol ingestion. All right. So we want to consider these causes, right, before we actually consider whether or not the patient has a true traumatic brain injury. All right, and okay, so there's been a lot of changes happening in EMS recently and ski patrol. I'm glad to see that this new textbook is referencing this topic here. Back in the day, or even as early as 5 years ago, right? Somebody had a head, neck, or back injury. Our immediate response was put them on a backboard, right? We are kind of moving away from backboards. And when we put somebody on a backboard, we are, this is spinal immobilization. But like I said, we are moving away from placing patients on backboards. Backboards have their own inherent problems. We're placing somebody on a rigid piece of plastic for upwards of many hours, right? So if we come up on somebody and we put somebody on a backboard, they're going to be on the backboard until EMS gets there. And for the ambulance ride down, and then until they get to the ER, and until they're cleared to take it off the backboard. Has anybody ever here just laid on their back, face up, on a flat, hard surface for 2 hours on end? You can imagine it probably doesn't feel very well, right? And what we were finding too is that many patients were having issues from the backboard with other kinds of pains and palsies and things like that that were making the backboarding much more worse than just not putting them on a backboard. So, now what we're doing is we're assessing whether or not these patients actually need to be on a backboard. We have this new term that is referred to as spinal motion restriction, or SMR. And really, all that's doing is we're just protecting the C-spine. So we're putting a collar on that individual so they're not moving their head, but we're allowing these patients to maintain a position of comfort. Really quick, I want to talk about something on this topic. Let me get out of PowerPoint here. There we go. Okay. So you guys should all be able to see my screen still, correct? Yeah. Perfect. All right. I'm going to pull something up here. So I want to quickly just go over, when we would or would not put somebody on a backboard. And to do this, I'm going to reference the SNHD protocols. I like the Clark County protocol that we have for EMS. I'm going to drop this in the chat log so everybody can see this. If I can figure out how to chat. I had it earlier. There we go, chat log, there we go. All right. So I am dropping this in the chat log. This is going to be our Clark County EMS protocols. Everybody should be able to see this on my screen now. And let's go down to all right. So within the protocols on page 139, we have a protocol that references cervical stabilization. So we see here that cervical stabilization is indicated in any patient who meets the following criteria. So if we have somebody that meets any of these criteria, then we want to do spinal motion restriction and basically put a collar on them and keep them from moving their head and allow them to maintain a position of comfort. So this is going to be midline cervical spinal tenderness. So what that means is that as you're assessing your victim, that you are taking your fingers and you are walking down each individual vertebrae and seeing if the vertebrae themselves are tender. We also can assess for focal neurologic deficit. So that's looking at, making sure they can move their hands, their feet, and making sure there's no neurological deficit. We can also assess for altered mental status, asking our 4 A&O questions, looking for any kind of drug or alcohol intoxication, or looking for any painful or distracting injury. We do not perform stabilization in the following conditions. Penetrating trauma to the head or neck with no evidence of spinal injury. Injuries where placement of a collar might compromise assessment, airway management, or ventilation or hemorrhage control, and patients in cardiac arrest. So if A through E in this first section are negative, then we do not need to apply a C collar. However, if one of those or all of those are positive, then we're going to go ahead and apply a cervical stabilization, which is a placement of a properly sized collar. And we are no longer taping down the head. So we no longer tape down the head of on a backboard. If the patient's in a motor vehicle, we're now asking them, even if they have spinal motion restriction in process or in play, we're simply asking them to get out of their vehicle on their own if they're able to. If not, then we move them. And then once they're on the stretcher, we're actually sitting these patients up in a semi-Fowler or high Fowler position. And then if we do use a backboard, backboards are still really good, specifically to act as a spatula. I love to use the backboard to pick patients up, but as soon as we're able to get them off, we get them off of the backboard. And then sometimes you may have to use another stabilization device like a vacuum mattress or TED. And then if it's a pediatric, we can place them in their car seat and stabilize them that way. So going back to the PowerPoint. So that pretty much is a more in-depth review of what we refer to as spinal motion restriction. Once again, we're no longer just backboarding patients, right? That used to be the thing back in the day where we would backboard patients and we would backboard everybody and anybody. But now we're simply doing spinal motion restriction where we place an appropriate size collar and have them sit up. In an unresponsive or altered mental status patient, if you suspect a spine injury in a trauma situation, spinal motion restriction is maintained during the assessment and treatment. When CPR is necessary, CPR takes priority. If we have multiple rescuers, we can have one person holding that spinal immobilization. For conscious and alert patients, oftentimes we can direct them to limit the movement of the spine, allowing the OAC technician to complete our assessment. So many times, I'll come up on somebody and I'll say, hey, don't move your head. And as long as they're able to follow commands and not move their head, we continue with our assessment. The assessment of a patient with a suspected spinal or spinal cord injury should include an exam of the skull, spine, and nervous system. So what that would look like is, assessing the head, assessing each individual vertebrae, walking down their back, feeling their back, along with making sure that they can feel in each hand and feel in each foot. Now, if they are wearing a helmet, we may need to remove a helmet. So it's only recommended that you remove a helmet if the patient does not have a patent airway, is not breathing adequately, and if the helmet prevents you from managing these problems. If the helmet is too big or allows the patient's head to move, we want to remove it. If it prevents us from placing a C-collar, we want to remove it. Any patient in cardiac arrest. In fact, let me grab my drawing tool. Any patient in cardiac arrest, we need to make sure their helmet comes off. And then if their helmet is broken, we want to go ahead and remove their helmet. Now, when assessing individuals, we haven't quite talked about this, but this is actually a very important thing that we want to assess for. So we want to check the helmet for its integrity. Can anybody think about why we want to check the helmet for its integrity?
Mechanism of injury.
Hit they took.
So mechanism of injury, and what else was in there? I heard somebody else say something.
So you can see how hard of a hit they took by just looking at the helmet.
Yeah, absolutely. Think about what those helmets are made out of, right? Those helmets are very durable, right? And if you crack or break a helmet, how much force do you think was involved to be able to crack that helmet? A lot of force, right? And if you think about it too, if the helmet is cracked, imagine what would have happened had the patient not been wearing a helmet. All right. I'm gonna erase all my notes here and let's move on. All right. So when we talk about assessment, we want to start by palpating the head before we remove the helmet. We want to check for pain and abnormalities such as depression of the skull. We want to check each spinous process. When we talk about the spinous process, those were those protrusions that we talked about earlier. And the way we're going to check them is by feeling each individual vertebrae of the back and neck. What we're looking for is misalignment or step off of a spinal process. Specifically, what we're assessing for is DCAP BTLS. So when we talk about DCAP BTLS, we're talking about deformity, contusions, abrasions, punctures, penetrations, burns, bleeding, bruises, tenderness, lacerations, and swelling. If you have not committed DCAP BTLS to memory, I highly recommend that you do, because in every exam I have ever taken for final cumulative exams, questions are asked about DCAP BTLS. And although I have not seen the final OEC exam, I can 99.9% promise you will see a couple questions on DCAT BTLS. So please make sure that you commit that mnemonic to memory.
Are these all things that we would do on the mountain, or would we wait till we get to FAR?
You know, really good question. It really depends on what you're doing, right? And where you are and your situation. And there are some things that, you know, definitely are going to hold off. So, you know, exposing the patient, taking their jacket off, you know, those, you know, doing a full head to toe body exam is going to be done in the first aid room. But, you know, for me, you know, when I come up on scene of something, you know, I'm going to do a quick body exam. Actually, give me 1 second. Let me grab somebody and I'll demonstrate a quick body exam to show you like what my process looks like coming up to somebody on the mountain. Give me 1 second. I'll demonstrate this. Hey, Bob. Let me borrow you. Let me borrow you. All right. So I'm back. I've got an assistant joining me. So let me go ahead and turn off my screen share. I've like totally lost my mouse. There we go. All right, mouse. All right, so we're going back. Stop share, still recording. All right. So, all right, Molly, come join me. All right, this is Molly. Say hi, Molly. Hi, Molly. All right. So, yeah, no. All right, so we have somebody. So Molly's, you know, been involved in a traumatic injury. Right? Usually when I come up on scene, you know, very first thing I do, hi, my name is Sam. I'm a ski patroller. Can I help you today? You know, and, you know, I'm assessing everything, you know, that I can see, right? So I can see that she's looking at me, right? I can see that she's tracking me. I can see that she's breathing. I can see that her airway's open. I might ask her, hey, what's your name? What's your name? So now that she's told me that she doesn't know her name, I'm now suspecting that we've got some kind of head injury, right? And then now I can go ahead. All right, do me a favor, Molly. Just look forward. Don't move your head. Keep your head like that. I'm just going to quickly feel your head. Any pain back here? Nope. All right. Nice deep breath. Take a breath. All right. Any pain in your hips? How about your legs? Do your legs hurt at all? All right. How about your arms? And that's my rapid body exam that I'm doing on the hill. And so, you know, we're trying to determine whether or not she has any neck pain. I might ask her a couple more questions. I might say, all right, so you don't remember your name, but do you know where you are today? No. Do you know what year it is? No. Who are you up here with? Some idiot. Some idiot? All right, probably me. You know, but now, you know, I'm trying to engage in that dialogue, trying to figure out what's going on, at the same time doing my rapid body exam. Now, am I on the hill, like grabbing my flashlight, looking in her pupils, doing her blood pressure, you know, doing a heart rate? Probably not going to do that on the hill. But I'm definitely going to do my rapid body exam. All right, any pain up on your head? Open wide, say, nothing there. Feel the back of the neck. Nice deep breath. Feel the pelvis, each leg, each arm. And that's my rapid body exam. Did that answer your question?
Yes, awesome. Thank you.
All right, bye, Molly.
Bye.
Thanks, Molly.
Oh, your hat. I'll probably be calling you back later. All right, so let's share. All right, so we're back on desktop. Everybody see my screen? We're good? Yes? All right. All right, so moving on. Good question. All right. So when we talk about neurological evaluation, this includes assessing for responsiveness. So, you know, determining where they are on the AVPU scale. I believe we talked about AVPU. What did AVPU mean?
Alert, verbal, pain, unresponsive.
Absolutely. So we're talking about AVPU. We're talking about somebody who's alert, somebody who responds to verbal. Sorry, trying to figure out what I'm doing here. Verbal, and then P, painful stimuli. And then lastly, somebody who is completely unresponsive. All right. And then we can look for spinal fluid leakage. What does that mean if we have spinal fluid leakage?
Fracture cranium.
Yep, so fracture somewhere in the cranial vault. We can assess for motor and muscle strength. So the way we do that is when assessing for motor and muscle strength, we're having the patient squeeze our fingers. So we take our fingers, we put them in their hands, we have them squeeze. We can also assess for each individual, like, hey, can you tell me what finger I'm touching? I usually like to go for the middle one because I can make a bunch of jokes out of it. And then we can also assess the feet. So I like to call it gas pedals, where we have them, push down on our hands and point their toes to their nose, and we're assessing the strength. We can assess for sensation and then function of the eyes. All right, and then we can use the AVPU scale to determine level of responsiveness. So patients with a neurological injury may have viewed normal, confused, agitated, combative, and comatose. I think my favorite story I like to tell of this, and I don't like to tell stories in class, but this is like my favorite story. I was a brand new ski patroller. I was maybe, I think, like a month on the patrol, and we used to have a half pipe, and we got dispatched to the half pipe. Hang on. All right. So we had a patient that went in the half pipe. He came out of the half pipe, and the witnesses said that he landed upside down, landed on his head. And I was one of the first patrollers on scene. I don't remember if I was the first or if I backed somebody up. And the dude was completely unresponsive. All right. Dude was completely out. And we start backboarding him. And as we start to backboard him, he starts to wake up and becomes unresponsive, or starts to become a little more combative, right? So now he's fighting us while we're putting him on the backboard and we're trying to tie him down. But here's where it gets really funny, okay? He's on his back, on the backboard, and he starts running in place on the backboard, talking about how he needs to make more pizzas and yelling, boss, I gotta make more pizza, I gotta make more pizza. And starts running in place on the backboard, on his back. So anyways, very good example of how these patients can present, right? They can present unresponsive, they can present confused, agitated, combative, they can be normal. We later found out from this individual's friend that he works at Little Caesars and makes pizza for a living. So, but when we have these individuals that, are unstable, we want to make sure that we're assessing every 5 minutes because their mental status can change, right? Even in this guy, he was changing by the minute. I think we ended up finding out that he had a brain bleed in like 13 different places. So yeah, he was really, really injured. All right, so we want to examine the ears and nose for leakage of CSF, which can indicate a skull fracture. We want to, let's see here, all skull fractures suggest a high impact MOI. What did MOI stand for?
Mechanism injury.
Mechanism of injury. All right. And it takes a lot of force to break the spinal column. So, or the skull, I should say. A lot of force to break the skull. So if we see a skull fracture, a lot of force involved. And the thing too is that we also need to consider what's below the skull. What energy got transferred below the structures of the skull. By itself, the CSF appears clear and colorless and can be mistaken for sweat, rain, or melted snow. In the setting of neurological trauma, we may see it mixed with blood. Damage to the spinal cord. So we can assess, let's see here, damage to the spinal cord in the neck causes neurological compromise of all four extremities. So that's where we can assess each extremity. In the thoracic or lumbar region causes neurological problems in just the legs. So we want to make sure we check the hands and the feet. Motor testing of nerves that come out of the spinal cord involve manually testing the arms and muscle groups, which I think we've already talked about that. All right, so we can see if they can touch the fingers of both hands, asking if they can feel it and to identify the finger. We can also check the eyes. This is an example of a patient that has that blown pupil where we have like a normal pupil on one side. Oh, let me grab the, I'm missing my pointer. There we go. Where we have a normal pupil on one side and the other side, the pupil is incredibly large, right? And this would indicate that we have pressure on cranial nerve 3. So this would indicate that we have some kind of bleed, right? So this would be like, like I said, pressure on cranial nerve trace. All right. So we want to make sure we are assessing the pupils. Get rid of my notes. All right. So we want to obtain a sample history and take a complete set of vital signs. When we talk about a sample history, what are we talking about? What does sample mean?
Signs and symptoms.
Signs and symptoms.
Allergies,
Allergies.
medications,
Events,
What does P mean?
events leading up.
pertinent
Past medical.
history,
Past medical history. L,
Last oral.
pastoral,
last oral intake. All right, I thought I heard Kelly in there. What was E?
Events last remembered, maybe?
Events leading up to the incident.
Leading up to, yeah.
trying to remember this long.
All right, and I lost my mouse again. Oh, there we go. On the other screen. All right. Oops. Go back one. All right. We can also assess for history. We want to find out if they have a history of seizures, diabetes, or if they take any alcohol or drugs. And we made it careful about the patient, for both medical problem and neurological trauma. All right, we want to do a complete head to toe, especially checking for fracture of the scapula and posterior ribs. Patients with suspected scapular or posterior rib fractures have a high incidence for spinal injury. Many spinal injuries are not isolated, so they may have additional extremity, chest, or abdominal injuries as well. We want to reassess every 5 minutes for changes. And with TBI, with increased intracranial pressure, we want to assess for increased systolic blood pressure, increased diastolic pressure, fast respiration, and bradycardia. Specifically, we referenced a triangle, and what was that triangle that we talked about?
Cushing's triad.
Cushing's triad. All right, so Cushing's triad was that increased blood pressure, that slow heart rate, and that irregular respiratory rate. Oh, remember this? Posturing. We kind of jumped ahead. And if you see here, in fact, I'm going to minimize that for a second. I'm going to Google quarter. I'm going to grab a quarter and place it into the slide. All right, so I've got a quarter here on the slide. And like I said, for decordicate posturing, I always remember decordicate posturing because the quarter kind of makes that circle, and I always think circle quarter or bringing it into the core. Okay, and then we have decerebrate posturing, where you see with decerebrate posturing that the extremities are pointed outwards. So you see here that the extremities are brought into the core. Oops. Ah, crap. What'd I do? I want to go back. There we go. All right. Grab my doohickey here. So we see here that the extremities are brought into the core, right? Creating that circle where we could put a quarter. Once again, step forward. Decerebrate, where we are posturing outwards. So now I will ask you, both are bad. Which one do you think is worse?
The decerebrate.
So do me a favor, in the chat log, let's kind of see what everybody says. Drop in the chat log whether you think decerebrate posturing is worse or decordicate posturing is worse. All right, so it looks like almost everyone's choosing decerebrate, decordicate. So yeah, so decerebrate posturing is way worse. So this is, both are bad. If you had to choose one, you'd want to be decordicate posturing. That's a little bit better. Decerebrate posturing is way worse. It requires much more to do so. All right, so let's talk about spinal motion restriction. So all transfers should be done with careful attention, limiting spinal motion. So we may want to use a stretcher or gurney, whole body vacuum splint, or backboard. When using spinal motion restriction, we want to make sure we use a cervical collar. The spine should be protected against movement with padding and bracing to fill the voids and strapping to limit movement laterally and axially. When a patient with a spinal trauma is moved without such precautions, damage to the spinal cord can occur. We may have unstable vertebrae or vertebral bone fragments, which may intrude into the spinal canal and put pressure on the spinal cord. When we talk about the decision to institute spinal motion restriction, we want to look at three things. One, the mechanism of injury. So we want to consider whether or not there's possible spinal injury. Two, we want to look at the reliability of assessment, and we want to consider the level of responsiveness of the patient and its effect on the credibility of the exam. And three, we want to look at exam findings, and we want to assess and determine if the physical findings support a spinal injury. There is an algorithm that NSP has developed where we look at the mechanism of injury, the reliability of the assessment, and the exam findings to determine whether or not we are going to put the patient on the backboard. Earlier, I referenced our Clark County protocols for EMS. I think that's a really good guide. Gives you kind of the breakdown, those points that you really want to assess for to see if we're going to place the patient on a collar or a backboard. So when we talk about required spinal motion restriction, we want to use spinal motion restriction if there is a potential MOI for spinal injury, normal mental status, or exam finding associated with spinal injury, a potential for spine injury, altered mental status such that the exam is not reliable, any positive physical finding on the exam. So what would be a positive physical finding that would make us want to place the patient in spinal motion restriction?
They fell greater than 3 feet or fell from a lift.
Yeah, so they fall from a lift. Yeah, absolutely. I'm putting them on a collar. How about something physical on your body exam?
Swelling or deformity of one of the spine, one of the vertebrates.
Okay, so we feel the back of the neck. We feel swelling or deformity. Anything else that you guys can think of?
That cracked helmet.
Yeah, the cracked helmet. Yeah, that's a good one. I like that. I heard bleeding in there.
Bleeding out of the ears.
Yeah, so we have that battle signs or that raccoon eyes. So bleeding to the head or
Pupil blown.
what was that?
Blown pupil.
Blown pupil, absolutely. Right? Leads us to suspect that significant damage to the brain.
Fluid coming out of the ears.
Yeah, 100%. Those would be all positive physical exam findings. And then moving to number 4, talking about a distracting injury. Can anybody describe to me what a distracting injury is?
It's an injury that you end up focusing on and not really looking at another injury because it's kind of, it appears worse or more painful for the patient at that time and miss the other one or takes away from the importance of the other one.
Exactly. When I talk about distracting injuries, my favorite reference is the movie Major Payne. Anybody remember the movie Major Payne? And when the ROTC kids get hurt, right? What does he do? He breaks their finger, right? Distracts their pain. That would be a distracting injury. Dean, you know exactly what I'm talking about now, don't you?
Yeah.
So that's what I refer to as a distracting injury, okay? And then any unresponsive patient involved in an unwitnessed trauma accident, since we don't know what's going on, that would be indication for spinal motion restriction. All right, so positive physical exam findings. Yeah, so midline tenderness, we feel the back. Loss of sensation and distal injury. Posturing, skin irregularity, CSF. Yeah, we talked about most of that. Perfect. All right. We do not need spinal motion restriction for low injuries, even with minor injuries. So low energy injuries, even with minor injuries. Can somebody think about what a low energy injury might be?
Bumping your helmet into someone else who was walking at you.
Great example. Yep. That would be a low energy injury. All right. We don't want to do spinal motion restriction as a just in case if there's an injury, like a low level probability. This was big with like gunshot wounds. Like, you know, somebody had like a stab wound or a gunshot wound, like gunshot to the chest, gunshot to the abdomen. And we're like, oh, we're going to put a C-collar on just in case. No, don't do that anymore. If they have a headache or a brief loss of consciousness for a few seconds or concussion, now otherwise alert-oriented patient, we don't need to do spinal motion restriction. Patients who are up and walking at the scene without physical findings or symptoms. We see this a lot, right? Patients were fine afterwards. They bounce back. We're like, oh, let's put a collar on you and back towards you. Nope, not anymore. And isolated penetrating trauma without spinal or neurological deficits, like a GSW, gunshot wounds, stabbings, things like that. All right, if you cannot obtain an adequate exam, so if you suspect a spinal injury and cannot obtain an adequate exam in the field, and it's more important to get the patient inside as quick as possible, use spinal restriction during transport. Once indoors and able to perform an adequate exam, if spinal restriction is not indicated, we can take them out of spinal restriction. This is not considered clearing the C-spine, but delaying your evaluation with restrictions. When in doubt, continue spinal motion restriction until EMS takes over. All right, so managing.
Hey, Sam.
Yeah, what's up?
Sam, so I was just listening, and I just kind of want to encourage everyone who gets up on the hill and when they start tobogganing and things like that, go ahead and take a ride in the toboggan without the backboard, and then go ahead and take a ride with the backboard so you know exactly what a patient might be experiencing. That's all I really wanted to add.
Thank you, Martha. Great point. You know, yeah, being able to experience what these patients experience. So I just realized it's 7:30. We've been at it now about an hour and a half. So before we get into management, what do you say we go ahead and take a 10-minute break? All right, so we were talking about how we're going to manage these individuals with head, neck, and back injuries. So the goals of emergency management of traumatic brain and spinal cord injury is 1, we want to fully assess the patient. 2, we want to adequately maintain vital signs. And 3, we want to avoid secondary injury while transporting the patient. Now, I'm going to go on a little soapbox right now, so I'm going to apologize to you. But my soapbox, it focuses on number 1. You know, nothing irritates me more than as a paramedic when I hear somebody of lower level, like either OEC or EMT, and they make the comment, there's nothing I can do for you. And basically my soapbox involves saying that comment because our job should be to fully assess, and we can do that, right? We can do a full patient assessment. And so, you know, with every patient, we should be making sure that we are completing our full body exam, doing a full and complete patient assessment. You know, being able to make a recommendation based on our assessment. So that's just my little tirade on making sure that we, you know, properly assess individuals. So when we talk about management of brain injuries, serious brain injuries are potentially life-threatening and require rapid transport to a definitive medical facility. Now, when we use this term definitive medical facility, went ahead. What are we referencing when we talk about definitive medical facility?
ER.
So you transport somebody. So, you know, we're very lucky here where we are. We have some trauma centers nearby, but you know, a definitive medical facility is somewhere that can actually take care of the patient, right? You know, the ER would be able to diagnose, but would an ER physician be able to relieve pressure of a brain injury? Not really, right? You know, that's got to be done by a trauma surgeon or neurosurgeon. So when we talk about definitive medical care, we're talking about that end all, you know, where they're going to receive that surgical intervention. So that would be, you know, a trauma center. So, you know, in these cases, you know, ER may not be their best bet. We may want to move them to somewhere with trauma services. And where do we have trauma services inside Las Vegas? We have 3 hospitals with trauma services. Can anybody identify them?
UMC Sunrise.
UMC Sunrise, and how about
Sienna.
that? What was that?
Sienna.
Sienna, absolutely. Ooh, I meant to erase. Erase. All right. So as an OEC technician, you are not expected to be able to differentiate between different types of serious brain injuries. Even as a paramedic, it's hard for me to tell you whether or not you have a subdural hematoma versus subdural hematoma versus epidural hematoma versus a brain contusion, right? So, you know, it's very hard for us to determine. You know, how do we determine those? I said it earlier, but how do we determine those?
You don't.
What was that?
You don't.
I mean, eventually they have to get determined. How do they get determined?
CT scan.
Absolutely, yeah. So we would need to have a head CT in order to determine those. And then we must be able to identify patients with signs and symptoms of significant brain injuries and arrange for appropriate transport to a trauma center capable of managing. You know, and when in doubt, always call for EMS. If you're ever unsure, just call EMS. So ABCDs of head and spine injuries. So care of patients with serious head or spine injuries consists of the following steps. We want to correct any life threats to the ABCDs that may be present while protecting the spine, especially the cervical spine. We want to perform CPR. We want to control severe external bleeding and maintain blood flow to the body tissues. We want to establish and maintain an adequate airway using a jaw thrust maneuver. If the patient's unresponsive, has no gag reflex, we want to insert an OPA or NPA, and we want to suction to keep the airway clear as needed. We also want to provide supplemental oxygen. You know, if breathing, put them on a non-rebreather. If they're not breathing, use a bag valve mask. We want to monitor supplemental oxygen, so making sure that we're keeping a pulse oximetry between 94 and 99%. So they talk here about hyperventilation and maintaining an oxygen saturation of 100% with oxygen is not recommended. Does anybody know why hyperventilation, and this used to be a thing where you know, we would hyperventilate patients with head injuries. This used to be common practice where if we had a patient with a head injury and a suspected brain bleed, we would actually go ahead and breathe faster for them, but they're no longer recommending this use in routine practice. Does anybody know why?
You want to flood the brain with oxygen?
Say again?
You want to flood the brain with oxygen?
Well, that was kind of the thought process with hyperventilating, but why don't we want to hyperventilate?
You get too much carbon dioxide in your blood.
So if you hyperventilate, you're going to blow off too much carbon dioxide. We're going to remove too much carbon dioxide. And we need a good amount of carbon dioxide in the body. So if we blow off too much, that can be a problem. Also, too, we always try to achieve a pulse oximetry between 94 and 99%. And the reason for that is to prevent over-oxygenation. So there can actually occur a situation where you over-oxygenate somebody. So if you have a pulse oximetry of 100%, you can't tell if you're over-oxygenating. Whereas if you're at 94 to 99%, you're right within that target of where you want to be. And then we also want to go ahead and take spinal precaution. So that's going to involve applying a collar and padding and backboarding as necessary. And then if time permits, treat minor injuries. So if there's severe brain or spinal injuries, transport as possible. If CSF is leaking, just basically cover it up. Don't attempt to stop it. Staying in line with number 4, that also involves, if you have fractures, other kind of fractures, splitting those as well. And then we want to transport the patient with their head uphill to prevent worsening of intracranial head injury. So if their head is facing downhill, that can lead to blood going to the brain even faster, whereas if the head's uphill, then they can have a decrease in that blood rush to the brain. We want to continually monitor the patient. We want to check level responsiveness and vital signs every 5 minutes and transport to a definitive care facility as soon as possible. So preferably somewhere with some kind of surgical intervention if they do have a brain bleed. Apparently we just went backwards in time. Let me get caught up here. Bear with me. All right, so if we have somebody with a head, neck, or back injury, we want to initially manually stabilize the neck and spine of any patient with the significant mechanism injury for potential head or spinal cord injury. If findings do not indicate the need for spinal motion restriction after quality spine and neurological exam, we can stop spinal mobilization. So initially what we're going to do is we're going to come up on scene. We're going to tell somebody, hey, don't move your head. Maybe hold their head nice and still. We do our exam, and if we find that we don't need to collar them, then don't put the collar on. Manual inline stabilization of the head and cervical spine is the first step in putting on a collar. So when we put on a collar, we want to hold their head nice and still, and then we'll go ahead and apply the collar. So to be effective, a cervical collar must be properly sized. It should rest on the shoulder of the patient. So we want to place it on the shoulder of the patient and lining it up with the bottom of the jaw. So a properly sized collar will restrict motion of the head and cervical spine in neutral alignment, not hyperextend the neck, and the chin will rest flush with the edge of the chin cup. And we don't want to make sure we do not hyperextend or flex the neck. An improperly sized collar will lead to airway compromise and airway patency, compromise cervical spine stability, and cause further injury. If the appropriate size is not available or if the collar cannot be applied appropriately, do not use it. Instead of a collar, we can use towel rolls. So basically roll a towel and then we can use them on each side of the head, or do a horseshoe blanket wrapped around the patient's neck. If the patient is supine, when log rolled, the procedure must be carefully executed to prevent any twisting or excessive bending in the spine. The log roll should be performed using at least 4 rescuers, and prior to beginning the log roll, make sure that the cervical collar has been applied. And then when we get into the skill sessions, we're actually going to go over how to apply a backboard and a C-collar. Talking about an axial drag. So an axial drag means that we're moving the patient in the axis of the spine. We want to make sure that we do a drag versus a pull or a push because we want to keep the spine in line. And typically we'll do axial drags once the patient is on a backboard to position them properly. And this will be one of those skills that we go over once we all meet. You can also move somebody onto a backboard using axial drag. Once again, we'll go over that. And then once properly positioned, we want to make sure the patient is properly secured on the backboard using straps, spider straps, tape, cravats, anything that we have. It's never a good day when you have to lift the patient up and they fall off your backboard. And then because the heads, so this is a very important concept. So let's take a few minutes to talk about this concept. In fact, I'm going to outline this because of how important it is. So children have these really big heads, and their heads are larger proportionally to their body, which means what happens if we place a child supine on a backboard? What's their head going to do?
Gonna tilt forward, their chin towards their chest.
Absolutely. So the chin is going to come towards the chest. So to prevent that, what we do is we place, can't see my pen there, but we're going to place padding beneath the child's shoulders. And what that's going to do is that's going to bring that head in that neutral inline position. So if we do have to backboard a kid or put a child on a nice flat firm surface, make sure you pad between the shoulder blades to allow them to keep their head in that neutral inline position. All right, and with seated patients, so not every patient will be sitting down. Sometimes they're wedged against a tree or rock or an automobile or sit down following their accident. You may need to manage these patients. Typically, with these seated patients, we use what we call a KED device. The KED devices are going away. They do have a great purpose. Where I've seen the KED really excel is patients caught in tree wells with a head, neck, or back injury. And we've used the KED in those cases. So for the sitting patient, if they cannot move on their own volition or who are reliable, they should be allowed to lay themselves down onto a stretcher or a vacuum mattress. And then we want to stabilize the head by placing cervical collar prior to having the patient move. And then we can get them on and do a backboard. For a standing patient, we can consider spinal immobilization, have them lay down on a backboard, or we can actually put them on a backboard using a standing technique. And then vacuum mattresses. I'm not going to cover too much about this. I might talk about this during the skill sessions because I have one at my office, but we don't carry vacuum mattresses at our patrol. But just know that with the vacuum mattress, it's basically like I like to think of the vacuum mattress of like a beanbag chair. Like if you were to sit on a beanbag chair and then pull out all the air, the little beanbags come together and it forms around your body. All right, so talking about helmet use, helmets are becoming more and more prevalent in the ski industry. We used to have a program, maybe we'll try to revive it, but we had a program called Lids and Kids where we gave out free helmets. We had a bunch of sponsors and we would give away free helmets to kids. And so basically we are seeing more and more uses of helmets. In fact, Patty, are you on the line? Or Martha, are you on the line? No, okay. I think that I'm like 99% positive. I should know the answer to this, but I am pretty sure that it is required of all staff at our ski resort, including patrol. If you are going to be on the hill, you have to wear a helmet. I believe that.
Hey, this is Martha. Sorry, it took me a while to get my pointer on.
Yeah, no worries.
Yeah, it's been that way for a number of years for volunteer and paid. I wouldn't see any reason why it would change. It came down from Powder Corps corporate. Does that answer the question?
It does. So, as you're getting ready for the season, please keep that in mind that you may have to, you will have to purchase a helmet and wear it on the slopes. Now, with the helmet, it does not, wearing a helmet does not appear to increase the risk of head or of neck or cervical spine injuries in adults. Even though the presence of a helmet can complicate the management of a patient, you may need to remove it to care for your patient. So we want to leave the helmet on if the helmet fits properly, does not obstruct the airway, does not interfere with assessment and management, and can be incorporated into proper spinal motion restriction of the spine. If the patient is standing or sitting and it's necessary to remove the helmet, you may allow the patient to remove their own helmet if they are willing and able to while you stabilize the head. It's recommended that if you remove a helmet, you do so only if the patient does not have a patent airway, is not breathing adequately, or prevents you from managing the airway. If the helmet is too big or otherwise allows the patient's head to move while it's left in place, prevents you from properly placing a cervical collar due to its size or shape, if the patient is in cardiac arrest, or if the helmet is broken and does not allow proper head, neck, and immobilization or visualization of injury. All right. So moving into jams and pretzels. So my 2 cents on jams and pretzels. I've been in EMS for like 16 years, 15 years, something like that. Of all the paramedic and EMT textbooks, I have never seen this except for in Ski Patrol textbooks. Ski Patrol is the only thing that talks about jams and pretzels. So with jams and pretzels, this is basically a way that we get patients into a neutral inline position. So patients who patients who incur serious injuries in the field are often found in a contorted position with severely angulated limbs. So therefore, we have to move them in a position to where we have them in an anatomically correct supine position. So we always want to remember to place a cervical collar prior to moving a patient, prior to performing jams and pretzels, or when spinal motion restriction is necessary. So basically what this is getting at is that patients are going to be found in 6 basic anatomic positions. They can be lying on their back, they can be lying on their stomach, they can be where their legs aren't aligned, or they could be in B, D, or F where they are Picasso is what I'll call it. And so pretty much what our job is to get them into this neutral inline position as shown in photo A, right? That's how we want to package our patients. So position 1, this is the where the patient is supine. It's a neutral anatomic position with the back straight, eyes forward, palms are straight with the extremities are straight with the palms against thighs. And this is how we should align our patients prior to going onto a backboard or movement of any kind. We want them in this position. Sometimes you might find them in 1A. With 1A, they're laying supine, but they're all sorts of bent. Position 2, the patient is on their side. So this is supposed to be, here, let me grab a draw icon. Pen. All right. So with this one, the patient is on the ground. So this is the ground. And the patient is on their side. And so what we want to do is we want to get them into the anatomic position, and so we can log roll them into that spot. 2A, they're on their side, and we see, once again, this is the ground and how they're all sorts of bent up. Once again, our goal is to get them into that position 1. And then when we talk about being prone, this means that they are laying face down. What is the issue with a patient who is laying prone?
Airway.
Airway, absolutely. We are unable to assess their airway. So what do we need to immediately do if we find this patient? So we find this patient laying on the ground prone. What do we have to do immediately?
Flip them.
Flip them, absolutely. All right, and then moving on into, moving forward. All right, 3A, they're once again prone and in all sorts of different position. So our goal is to get them into position 1. So we want them on their back with their eyes forward so that we can roll them onto a backboard if needed. When we talk about the back, or the posterior, so posterior, this is the back. And then the anterior is the front. So our 3 important posterior reference points are the head, shoulders, and hips, and the anterior reference points are the nose, navel, and toes. So when we talk about extricating patients, or we talk about this term stabilized extrication. So the process of placing a patient into an anatomic alignment is termed stabilized extrication. So the goal of stabilized extrication is to align the patient so that the 3 posterior reference points remain aligned in both the vertical and horizontal planes. And the key to performing stabilized extrication then is to keep these 3 reference points both aligned in the same plane while the patient is being moved. When this is accomplished, the spine will be stabilized and little or no motion will occur in the spinal segments. And when properly positioned, the 3 anterior points should also form a straight line. All movements should be coordinated by the OEC technician or by a lead OEC technician, and rescuers must move in a smooth manner without hesitation and in unison following our leader's directions. We want to manually stabilize the posterior reference points at all 3 times. So we want to move the patient axially by sliding or vertically by lifting and lowering, but never move a patient sideways. Why don't we want to move a patient sideways?
Spinal damage.
Absolutely. So we want to move them in that long axis, right? So we want to go in the axis of the spine. And we want to keep increments in about 6 to 12-inch movements. All movements are started and stopped on the leader. And when the patient's limbs, head, or neck need to be straightened, we want to move only 1 joint at a time in only 1 plane. This is really big. Anytime we're going to move somebody, we want to move only 1 joint in 1 plane at a time. All right. So we want to align all the body parts into positions 1, 2, and 3 as early as possible, unless there's major resistance. What happens if you incur major pain or resistance?
Stop.
Yes, stop doing what you're doing and reevaluate. What happens if you can't put something into a neutral inline position? Then what do you do?
Get them to position of comfort and strap them down and move them slow, as carefully as you can.
Yeah, you may have to immobilize somebody and splint somebody in very weird and awkward positions. We want to keep the number of positions minimum, and we want to generally try not to progress from a higher number position to a lower number position. All right. So case study. Ooh, getting towards the end. All right. So you are dispatched to an accident. Skier has collided with a large tree. Upon your arrival, you find an unresponsive male skier, approximately 30 years old, lying on his back. So we make sure the scene is safe, right? So we have a safe scene. You prioritize by carrying life-threatening problems. What are our life-threatening problems? What are we looking for?
A, B, C, D.
And what are those? Not just the beginning of the alphabet. When we talk about A, B, C, D, E, what are we looking for?
Airway, breathing, circulation, and deformity.
Perfect. All right. So we're looking to make sure the airway's open. We're looking to make sure they're breathing. We're looking to make sure they're not obviously bleeding. And we're looking to make sure that, you know, they acknowledge us and they know what's going on. All right. So next, you recognize the need for airway management. So actually, no excessive bleeding. You recognize it for airway management. Using techniques to minimize the injury, you immediately open with a jaw thrust and check for a pulse, or check for breathing and a carotid pulse. Why do we use a jaw thrust in this case?
Spinal possibility.
Spinal possibility, absolutely. And then we go ahead and we place an OPA. What does placing an OPA tell us?
Their airway is going to stay open?
So it tells us their airway is going to stay open, but what else? If the patient accepts that OPA, what else does that tell us?
He's unconscious, unresponsive. He can't feel pain. If he can accept it, he doesn't feel any pain.
Absolutely. He's unconscious, unresponsive. And does that instantly elevate your level of what I refer to as your level of oh shit factor? Absolutely, right? You know, that's raising my level of like, hey, we need to get going now. Like, we need EMS, we need an ambulance, you know, we need a helicopter. Like, we need to get this patient off the hill as quickly as possible. And then you see that he's wearing a helmet that is cracked in 2 places. What does this tell you with the helmet that is cracked?
That's a huge hit.
Absolutely. So think
High speed
about
impact.
Was that?
He's high speed impact. So he's got deceleration trauma.
Absolutely. High speed impact. So, think about what's happening underneath, right? Think about the trauma. Think about the effects of the brain that is happening underneath that helmet, right underneath the brain. And so we see here that blood and clear fluid are leaking from the patient's nose. What is that clear fluid?
Spinal.
Yeah.
CSF, cerebral
Yes.
spinal fluid. All right. And the ski tracks indicate the patient went straight into a tree. So now it asks you, what should you do?
Fight for life.
Yeah, absolutely. I'm calling Mercy Air. I'm calling for an ambulance. I'm calling for backup. I'm calling for a trauma toboggan. I'm calling for a trauma pack. In fact, I'm just calling everybody, right? We want everything and anything. All right. And then, all right. So the patient is unresponsive. You immediately call for assistance. You instruct rescuers to bring a long backboard, cervical collar, oxygen, and trauma pack. You also request a toboggan and advanced life support. The patient's pulse is 60 beats per minute and regular. Are you guys concerned with this 60 beats per minute?
No.
I would think it would be a little low for just coming off of skiing, but
I think it's kind of low for being active and being at altitude.
So I
It's
agree.
low, but he has other problems.
So hang on. So we have a couple things going on here, right? So we're at altitude, right? He's been skiing and his body was just involved in a major insult, right? How does your body compensate after you've been involved in a major insult? Like, what's the very first things to happen?
Fight or
What's
flight.
Goes up.
shock.
Heart rate goes up, right? So in this case, I would expect his heart rate to go up. But the fact that his heart rate is at 62 beats per minute, what does that tell us?
Shunnings or whatever. Shunning.
Cushing's triad.
Cushing's triad. And what was Cushing's triad?
Elevated blood pressure, low heart rate, and irregular respirations.
Absolutely. So this heart rate in the 60s, although it's still within that normal range, it's like right on the baseline, and I'd expect it higher. So I am really worried that this person has a head bleed, right? And that we have some kind of intracranial trauma setting in. So we've got some kind of bleed. And with that bleed, that means that we have that increase in pressure. And so, this patient is, very sick. We need to get them off the hill as quickly as possible. So as you await help, you continue to maintain spinal motion restriction. At the same time, you visually assess the patient's injuries. He's got contusions on the right facial cheek and his forehead, and soon other additional rescuers arrive. So what should you do?
You got to give him a C-collar or spinal precautions to get him out of the tree well.
Absolutely. So we want to get him out of the tree. You know what I'm doing initially? The very first thing I'm doing as lead in charge, I'm having somebody else take over C-spine, and now I'm standing back and directing. So consider that, right? If you're in charge, right, stand back, and now you have control of the scene, and you tell everybody, what you want them to do. So I'm going to have somebody come in, take over C-spine. I don't want to be on C-spine as I'm in charge. And then I'm going to go ahead and direct people to, let's get them on a backboard. Let's get them out of the tree. Let's get the toboggan loaded. Let's get them on oxygen. And let's get them off the ski slope as quickly as possible. We also want to consider doing that rapid body exam. So going over each major body system as quickly as possible to see if there's any other injuries. All right, so what do we see? You instruct one OEC technician to take over manual inline stabilization. You instruct another to place the patient high flow oxygen. You palpate the entire body and find no other injuries. You place a cervical collar on the patient, and with the assistance of other patrollers, you log roll onto a long backboard. Vital signs remain stable. You provide spinal motion restriction with strapping, securing the patient's head to the backboard. You load him onto a toboggan with his head uphill and quickly transport to a landing zone where he's transferred to a helicopter after you give them a brief about what happened, and then the patient is flown to a trauma center. During your monthly patrol meeting later that week, you learned the patient had a linear skull fracture with an epidural hematoma and a fractured vertebrae at C6 and neurogenic shock. Although the patient's condition is serious, he appears to be making progress and reportedly has a good chance to return to normal life. The neurosurgeon was impressed with your care the patient received in the field and commends you and your team for recognizing the severity of the brain injury, protecting the patient's spine, and getting him to the hospital rapidly. All right, question for you. How often does a neurosurgeon come back to Ski Patrol and say, good job, guys? Never. I can't say I've ever had a neurosurgeon come back and say, EMS and Ski Patrol, we appreciate you guys. But hey, in this scenario, it's there for feel good. All right. So activities, I'm not going to worry too much about the activities. You guys can read about them in your book. And then, we're going to hit these when we actually do our skill sessions coming up. Hopefully next year, once we can be able to return to in-person learning. That brings us to the end of the program. Does anybody have any questions about tonight? Anything I can answer?
So I have a question. On one of the quizzes was an ambiguous question, I thought, and it pertains to tonight. And it says, a mother brings her 7-year-old child to the aid room, tells you that that fluid is draining from the child's ear. She tells you the child had a fever since this morning, was complaining of right ear pain. Based on the OEC training, you would. And I chose arrange for ALS transport immediately. But the correct answer said, have the boy lie on his right side to allow fluid to drain. And that seemed like, I don't know, didn't seem like you'd want to roll him onto his right side.
And what chapter was this?
I don't know, because like we were talking about earlier, we can't really put, I just screenshot every time I see a wrong answer, so I screenshot it.
Yeah.
And I'm not sure what this one was, but I can, yeah, I'm not sure. But that was what the...
Okay. Wonder if it's back.
What were the other choices?
Use a 4x4 to pack the ear, and then the bandage it securely using gauze around the head. Put a pressure dressing over the ear to stop the drainage. Have the boy lie on the right side and allow the fluid to drain, or arrange for ALS transportation immediately. I figured if you had spinal fluid coming out of the ear, would have been the better of all four. I didn't think of lying him on his side to let the fluid drain out. I don't know.
I'm wondering if it's infection related opposed to like spinal fluid.
Say that again.
If the child had a bad infection, maybe it was a rupture of the tympanic membrane, and that's the fluid that's draining opposed to spinal fluid. That's maybe where they're going with that. I don't know.
Right. Maybe, yeah.
But also the child had a fever in the morning. Didn't say anything about trauma. So that would you'd weigh those two. And would you really call ALS if there was no trauma?
Well, I just assumed spinal fluid coming out of the ear, and since that's not something you see every day, I figured.
So what would cause spinal fluid to come out of the ears?
Pressure.
Pressure. What else?
Trauma.
Trauma. Basically trauma.
Okay.
So I think by the word fever, that sort of gave you a clue.
Gotcha. Okay. That was just one of those ambiguous questions that I wondered.
Yeah.
Gotcha.
I'll look it up.
Okay, maybe I'll figure it out by looking at the rest of my questions.
I got it. It's chapter 22.
Oh, okay.
Yeah. So this one was, face, eye, and neck injuries. That was chapter 22. And yeah, like Patty said, and I forgot who else said, but that fever being the key and complaining of right ear pain. So basically it sounds like a right ear infection. And so because it seems like an ear infection, you know, and fluid is draining, we want to allow fluid to drain. Now, I guess, you know, this is one of those questions that, you know, in the presence of tonight or tonight's lecture, I would agree, call for ALS if the question was based on tonight's lecture. But because it was based on chapter 22, which I think was last week or 2 weeks ago, on specifically head, neck, and spine, or face, eye, and neck injuries, what they're trying to go with is you have a sick kid who's a tympanic membrane ruptured.
Thank you.
Anything else?
I had a question. Like, what would your advice be if you had a patient who's P on the AVPU scale? So he's not verbal, he's not alert, but not unconscious. And it's suspect brain spinal injury, but they're moving around, whether they're writhing in pain and stuff. And you need to try to get them on the toboggan or a litter, essentially stabilize, but you don't want to wrist strain them, but they're not responsive in a way that, you know, they're not accepting any commands to sit still.
Yeah, so, you know, these are oftentimes very difficult patients to work with when they're, you know, the P on the AVPU scale, right? So, you know, they're not following your commands. They're not completely unresponsive. You know, these individuals, you know, perfect example, right? Boss, I got to make pizza, right? I gave you that example. I think that's like the example that you're going for, right? You know, guy is like, you know, running on the backboard, right? You know, talking about how he needs to make pizza for work. And yeah, so, you know, really, you know, in that case, it is protecting the patient, you know, talking to them in, you know, as calm a voice as you can, you know, continuing what you're doing and using a lot of straps to be able to, you know, get that patient secured and immobilized down. The great thing is once EMS gets there, once, you know, the paramedics arrive, you know, now we can go ahead and sedate the patient and get them down. But until then, you know, really it's keeping them as calm as possible. And, you know, you may have to restrain them or tie them down. And we've had to do that plenty of times where you have that patient that's, you know, not quite verbal, not quite painful. They're trying to get up. They don't know what's going on. Their brain's currently resetting. They've got different bleeds going on, and they're combative. And it's not they're combative because they're a bad person. They're combative because their brain just got scrambled. They're in the flight or fight, you know, mechanism.
Sure.
That's when you recruit family and friends, because somebody familiar to them can talk to them a little easier.
Yeah.
And they're not gonna respond to you.
Absolutely. All right. Anything else? All right.
Yeah,
So, yeah, go ahead.
I noticed earlier you said like if someone's laying face down, it's important to try to get them face up.
Yep.
But what if like you suspect that it's like some sort of spinal injury? Like how do you go about flipping them all the way? Should I wait for someone to help me, or that's what I'm wondering.
Can you guys see my whiteboard?
Oh yeah.
I'm more or less having fun with my whiteboard right now. But basically, yeah, you know, the airway is priority, right? And so you may be in a situation where you have to quickly roll a patient over to get that airway open. You know, your airway should always be priority. Without airway, you got nothing.